Welcome to our comprehensive guide on parasitic diseases. In this video, we'll explore the major types of parasitic diseases, their causes, symptoms, and the latest treatment options. Parasitic diseases are a significant global health concern, affecting millions of people each year. They can be caused by protozoa, helminths, or ectoparasites, each with unique characteristics and health impacts. Understanding these diseases is crucial for prevention, early diagnosis, and effective management. Let's begin by categorizing the main types of parasitic diseases and setting the stage for a deeper dive into each category. Parasitic diseases are generally classified into three main groups: protozoan diseases, helminthic infections, and ectoparasitic infestations. Protozoan diseases include giardiasis, amoebiasis, malaria, and Chagas disease. Helminthic infections cover conditions like ascariasis, enterobiasis, hookworm, strongyloidiasis, and cestodiasis. Lastly, ectoparasitic infestations are commonly seen as head and body lice. Each group has distinct modes of transmission, clinical presentations, and treatment approaches. In the following scenes, we'll examine each group in detail, starting with protozoan diseases. Protozoan diseases are caused by single-celled organisms that can infect various parts of the body. Among the most common are giardiasis, amoebiasis, malaria, and Chagas disease. These illnesses often spread through contaminated water, food, or insect vectors. Protozoan infections can lead to a range of symptoms, from mild gastrointestinal discomfort to severe systemic illness. Early detection and appropriate therapy are essential to prevent complications. Let's start our detailed exploration with giardiasis, a widespread intestinal protozoan disease. Giardiasis is caused by Giardia lamblia, also known as Giardia intestinalis or Giardia duodenalis. It's the most common intestinal parasite responsible for diarrheal syndromes worldwide. Children are particularly susceptible, but adults can also be affected. Infection typically occurs after ingesting Giardia cysts in fecally contaminated water or food. Once inside the body, the parasite undergoes changes in the stomach and small intestine, leading to colonization and multiplication. This process can result in significant gastrointestinal symptoms and malabsorption. After ingestion, Giardia cysts exist in response to low gastric pH, releasing trophozoites. These trophozoites colonize the small intestine, leading to mucosal invasion, localized swelling, and flattening of the intestinal villi. This damage impairs nutrient absorption, resulting in malabsorption syndromes. The clinical presentation can vary, but often includes acute onset diarrhea, abdominal cramps, bloating, and flatulence. Some individuals may also experience malaise, loss of appetite, nausea, and belching. Let's look at the acute and chronic symptoms in more detail. Giardiasis can present acutely or chronically. In the acute phase, patients often report sudden diarrhea, cramp-like abdominal pain, bloating, and excessive gas. Other symptoms include malaise, anorexia, nausea, and frequent belching. In chronic cases, diarrhea becomes foul-smelling, light-colored, and fatty, often accompanied by weight loss. Patients may experience alternating periods of diarrhea and constipation, steatorrhea, lactose intolerance, and deficiencies in vitamin B12 and fat-soluble vitamins. These symptoms can significantly impact quality of life if left untreated. Diagnosis of giardiasis relies on laboratory testing. The most common method is the enzyme-linked immunosorbent assay, ELISA, which detects Giardia antigens in fresh stool samples. Alternatively, microscopic examination can reveal trophozoites or cysts, especially during the acute diarrheal phase. Accurate diagnosis is crucial for guiding treatment and preventing further spread. In some cases, multiple stool samples may be needed to confirm the presence of the parasite, as shedding can be intermittent. Treatment of giardiasis in symptomatic adults and children over 8 years old typically involves metronidazole 250 mg 3 times daily for 5 to 10 days. Alternatives include tinidazole 2G as a single dose or nitazoxanide 500 mg twice daily for 3 days. Other options are furazolidone or paramomycin, with paramomycin being a safe choice during pregnancy. Prompt treatment not only relieves symptoms, but also reduces the risk of transmission to others. For children, dosing is adjusted by weight. Metronidazole is given at 15 mg/kg/day in 3 divided doses for 5 to 7 days. Tinidazole is dosed at 50 mg/kg up to 2G as a single dose. Nitazoxanide suspension is dosed at 100 mg every 12 hours for ages 1 to 3, 200 mg every 12 hours for ages 4 to 11, and the adult dose for those over 12, all for 3 days. These regimens are effective and safe when administered correctly. Amoebiasis is primarily caused by Entamoeba histolytica. This protozoan invades the mucosal cells of the colon, producing necrotizing ulcers in the submucosa. The trophozoite form releases toxins that damage cells, and if it enters the portal circulation, it can reach the liver, causing abscesses and periportal fibrosis. In severe cases, ambic ulcers can affect the colon, perineum, genitalia, and even spread to the lungs or brain. Most common manifestations of amoebiasis include abdominal pain, diarrhea, and sometimes dysentery with blood and mucus in the stool. In more severe cases, patients may develop liver abscesses, presenting with fever, right upper quadrant pain, and tenderness. Abscesses can also occur in the lungs or brain, leading to more complex clinical pictures. Early recognition and treatment are vital to prevent complications. The primary goals in treating amoebiasis are to eradicate the parasite and provide supportive care. Treatment regimens vary depending on the type of amoebiasis: asymptomatic cyst passers, intestinal amoebiasis, or ambic liver abscess. Supportive therapy includes electrolyte replacement, antibiotics for secondary infections, and nutritional support. In some cases, large hepatic abscesses may require drainage procedures before starting drug therapy. Amoebiasis treatment often requires a combination of drugs. Tissue-acting agents like metronidazole, tinidazole, dihydroamidine, and chloroquine target parasites in tissues, while luminal agents such as iodoquinol, diloxanide furoate, and paramomycin clear parasites from the intestinal lumen. The choice of agent depends on the disease category and patient factors. Using both tissue and luminal agents ensures complete eradication and prevents recurrence. For asymptomatic cyst passers and mild intestinal amoebiasis, recommended luminal agents include paramomycin 2530, 5 mg/kg/day in 3 doses for 7 days, iodoquinol 650 mg 3 times daily for 20 days, or diloxanide furoate 500 mg 3 times daily for 10 days. Pediatric dosing is similar, with adjustments for weight. Paramomycin is preferred during pregnancy due to its safety profile. Patients with severe intestinal disease or liver abscess should receive metronidazole 750 mg 3 times daily for 10 days, followed by a luminal agent. Tinidazole 2G once daily for 5 days is another option for liver abscess. Pediatric patients receive oral metronidazole at 50 mg/kg/day in divided doses, also followed by a luminal agent. This two-step approach ensures both tissue and intestinal parasites are eliminated. Malaria is a life-threatening disease caused by Plasmodium species, transmitted by the bite of infected Anopheles mosquitoes. The main species include P. falciparum, P. vivax, P. malariae, and P. ovale. Malaria remains a major public health challenge in many parts of the world, particularly in tropical and subtropical regions. Understanding its transmission and life cycle is key to effective prevention and treatment. Malaria transmission begins when an infected mosquito injects sporozoites into the bloodstream. These sporozoites travel to the liver, where they multiply and form schizons. After rupturing, they release merozoites that infect red blood cells. The asexual cycle continues in humans, while the sexual stage occurs in mosquitoes. Some species, like P. vivax and P. ovale, can remain dormant in the liver, causing relapses months or years later. The erythrocytic phase of malaria leads to extensive destruction of red blood cells, causing anemia and enlargement of the spleen. P. falciparum is particularly dangerous due to its ability to infect red blood cells of all ages, resulting in high levels of parasitemia. This can lead to severe complications, including cerebral malaria, kidney failure, and respiratory distress. Early diagnosis and treatment are essential to prevent these life-threatening outcomes. Malaria typically presents with fever, chills, headache, muscle aches, and fatigue. In severe cases, patients may develop jaundice, confusion, seizures, or difficulty breathing. The classic pattern of fever spikes every 48 to 72 hours is seen in some types, but not all. Laboratory diagnosis is made by identifying Plasmodium species in blood smears. Let's look at some visual examples of malaria's clinical presentation. The primary goal in managing malaria is rapid diagnosis using blood smears, repeated every 12 hours for 3 days if needed. Early detection allows for timely initiation of antimalarial therapy, aiming to eradicate the infection within 48 to 72 hours. Preventing complications such as hypoglycemia, pulmonary edema, and renal failure is crucial for reducing mortality. Monitoring response to therapy is an essential part of care. For adults, including pregnant women, chloroquine phosphate 300 mg once weekly is recommended for all Plasmodium species, starting 1 to 2 weeks before travel and continuing for 4 weeks after leaving an endemic area. Pediatric dosing is 5 mg/kg, up to 300 mg. For areas with P. vivax or P. ovale, primaquine phosphate is added for 14 days. In regions with chloroquine-resistant P. falciparum, mefloquine or alternatives like doxycycline are used. Children receive chloroquine at 5 mg/kg weekly and primaquine at 0.6 mg/kg daily for 14 days when indicated. In chloroquine-resistant areas, mefloquine is dosed at 15 mg/kg, followed by 10 mg/kg. Doxycycline is an alternative for children over 8 years old, but is contraindicated in younger children, pregnant women, and breastfeeding mothers. Proper prophylaxis is key to preventing malaria in travelers and residents of endemic areas. For uncomplicated malaria, excluding chloroquine-resistant P. falciparum, adults receive chloroquine 600 mg initially, then 300 mg at 6 hours, followed by 300 mg daily for 2 days. In severe cases, or when oral therapy isn't possible, IV quinidine gluconate is used, followed by oral quinine and doxycycline to complete 7 days of therapy. Pediatric dosing is adjusted by weight. Clindamycin replaces doxycycline in young children and pregnant women. In severe malaria or chloroquine-resistant P. falciparum, IV artesunate is recommended, followed by oral quinine plus doxycycline or clindamycin. Mefloquine or atavaquone malurone are alternatives for resistant cases. Artemether cordum is another FDA-approved option. Treatment regimens are tailored to the patient's age, pregnancy status, and drug tolerance. Close monitoring is essential during therapy. Therapeutic outcomes are monitored by checking blood smears every 12 hours until parasitemia drops below 1%. Blood should be clear of parasites within 5 days, and fever should resolve within 36 to 48 hours after starting IV therapy. If parenteral therapy is needed for more than 48 hours, the quinidine dose should be reduced. Monitoring ensures effective treatment and helps prevent complications. Helminthic diseases are caused by parasitic worms, including nematodes, cestodes, and trematodes. Common nematode infections include hookworm disease, ascariasis, and enterobiasis. These infections are prevalent worldwide, especially in areas with poor sanitation. Symptoms vary depending on the type of worm and the organs involved. Let's start by looking at hookworm disease. Hookworm disease is caused by Ancylostoma duodenale or Necator americanus. Adult worms attach to the small intestine, where females lay eggs that are passed in feces. Infective larvae can enter the body through contaminated food, water, or by penetrating the skin. This can cause a localized skin reaction before the larvae migrate to the intestines, leading to further symptoms. Symptoms of hookworm infection include mild epigastric pain, headache, fatigue, anemia, and hypoproteinemia. Cutaneous larva migrans may also occur. The first-line treatment is mebendazole 100 mg twice daily for 3 days, which is also effective against other nematodes. Pediatric patients over 2 years receive the same dose. Albendazole is an alternative therapy. Early treatment prevents complications like severe anemia. Ascariasis is caused by the giant roundworm Ascaris lumbricoides. During the larval migration through the lungs, patients may develop pneumonitis, fever, cough, and eosinophilia. Other symptoms include abdominal discomfort, obstruction, vomiting, and sometimes appendicitis. Diagnosis is made by identifying characteristic eggs in the stool. Ascariasis is common in areas with poor sanitation. Both adults and children over 2 years are treated with mebendazole 100 mg twice daily for 3 days. Albendazole 400 mg as a single dose is an effective alternative. These medications are highly effective and well tolerated. Early treatment is important to prevent complications such as intestinal obstruction or secondary infections. Enterobiasis, also known as pinworm infection, is caused by Enterobius vermicularis. The pinworm is a small, thread-like worm, about 1 cm long. Children are most commonly affected. The main symptom is intense itching in the perianal region, especially at night, due to migrating female worms and egg deposition. Scratching can lead to dermatitis and secondary bacterial infections. Treatment options for enterobiasis include parenteral pamode, mebendazole, or albendazole. For adults and children over 2 years, parenteral pamode is given at 11 mg/kg, up to 1 g, as a single dose, repeatable in 2 weeks. Mebendazole 100 mg or albendazole 400 mg are also effective single doses, both repeatable after 2 weeks. Treating all household members is recommended to prevent reinfection. Other important helminthic infections include strongyloidiasis and cestode infections like Tinea solium, which can cause cysticercosis and neurocysticercosis. These conditions may require specialized diagnostic and treatment approaches. Reading assignments and further study are recommended for a deeper understanding of these diseases and their management. Bone and joint infections include osteomyelitis and septic infectious arthritis. These are distinct entities with different signs, symptoms, and causative organisms. Osteomyelitis refers to infection of the bone, while septic arthritis involves inflammation within the joint space. Both conditions require prompt diagnosis and treatment to prevent long-term complications. In adults, osteomyelitis often results from contiguous spread, such as postoperative infections or those associated with adjacent soft tissue infections. Hematogenous osteomyelitis, which spreads through the bloodstream, is less common in adults, but more frequent in children. Patients with significant peripheral vascular disease are also at increased risk. Understanding the epidemiology helps guide prevention and management strategies. Osteomyelitis can be classified by duration and mode of acquisition. Acute cases last less than 2 weeks, subacute 2 to 4 weeks, and chronic more than 4 weeks. Hematogenous osteomyelitis results from bloodstream spread, while contiguous osteomyelitis arises from adjacent soft tissue infections. Direct inoculation can occur through trauma, puncture wounds, or surgery. Each type has unique clinical features and management considerations. Infectious arthritis can be caused by various microorganisms, most often affecting a single joint, monoarticular, but sometimes involving multiple joints. The infection usually reaches the joint via the bloodstream, though spread from osteomyelitis or direct inoculation is possible. Children and the elderly are most commonly affected, with about 1/3 of cases occurring in children under 2 years old. Hematogenous osteomyelitis is typically a disease of growing bone in children, with most cases occurring in those under 16. In adults, vertebral osteomyelitis is more common, especially in those over 50. The unique vascular structure of long bones predisposes them to infection, as slow blood flow in the metaphyses allows bacteria to settle and initiate inflammation. This can lead to a vascular necrosis and chronic infection. Infection in the bone can lead to a vascular necrosis, especially if large segments become devitalized. This impairs antimicrobial delivery and makes the infection prone to exacerbations. Chronic osteomyelitis may result in weakened bone or the formation of draining sinuses to the skin. Staphylococcus aureus is the most common pathogen, responsible for over 80% of cases, with other bacteria playing smaller roles. Neonatal osteomyelitis can be caused by group B streptococcus and Escherichia coli, in addition to Staphylococcus aureus. Vertebral osteomyelitis is most common in adults aged 50 to 60, often affecting the lumbar and thoracic spine. Gram-negative organisms, including E. coli, are increasingly significant in these cases. Understanding the causative organisms helps guide appropriate antibiotic therapy. Direct inoculation osteomyelitis occurs when organisms enter the bone from outside the body, such as through trauma, open fractures, or surgery. Over 80% of postoperative osteomyelitis cases follow open reduction of fractures. Puncture wounds to the feet are often associated with gram-negative infections, especially Pseudomonas aeruginosa, but Staphylococcus aureus remains a significant pathogen. Osteomyelitis can also result from the spread of infection from adjacent soft tissues, such as pressure ulcers or dental infections. This form most often affects older adults, particularly those with hip fractures or vascular disease. Unlike hematogenous osteomyelitis, contiguous spread disease is frequently polymicrobial, involving staphylococci, streptococci, gram-negative bacilli, and anaerobes. Patients with severe vascular insufficiency, such as those with diabetes or atherosclerosis, are at high risk for contiguous spread osteomyelitis. These infections often involve the toes and fingers and are almost always polymicrobial. Management is challenging due to poor blood supply and the presence of multiple pathogens, including staphylococci, streptococci, enterobacteriaceae, and anaerobes. Infectious arthritis is usually acquired through hematogenous spread, as the synovial tissue is highly vascular and lacks a basement membrane. This allows organisms in the blood to easily reach the joint space. Some bacteria, like Neisseria gonorrhoeae, are particularly likely to infect joints during episodes of bacteremia. Prompt recognition and treatment are essential to prevent joint destruction. In summary, parasitic diseases encompass a wide range of conditions caused by protozoa, helminths, and ectoparasites. Early recognition, accurate diagnosis, and appropriate treatment are essential for effective management and prevention of complications. Bone and joint infections, though distinct, also require prompt attention to avoid long-term damage. Staying informed about these diseases helps protect individual and public health.